So good evening everyone. Today we will discuss about updated results of ADAURA trial. Osimertinib has been shown its efficacy in metastatic lung cancer with EGFR mutated patients, but does it also work in adjuvant setting? To answer this question, ADAURA trial was designed. Next slide please. So this was the trial design. Patients who were resected and having margins negative, having stage 1B, 2 or 3 NSCLC with EGFR mutation positive, either exon 19 deletion or L858R. Patients who were having performance status of 0 and 1, they were randomized according to the stage 1B versus 2 or 3A, and according to EGFR mutation, exon 19 deletion and L858R, to osimertinib or placebo, and the drug was continued till the recurrence of disease. And the primary endpoint was DFS in the stage 2 and 3A patients, and secondary endpoints were DFS in overall population, DFS at 2, 3, 4 and 5 years, overall survival, safety and quality of life. Next slide. So these are the results of primary analysis of ADAURA trial after 1 year of completion of therapy, and we can see that there was significant improvement in primary endpoint DFS. In this curve is for stage 2 and 3A population, that was the primary endpoint. Here we can see that there was significant improvement in DFS with hazard ratio of 0.17, and this is overall population. Here also we can see that the curves were separated from the beginning, and there was significant improvement in DFS. So in next few slides, we will discuss about updated analysis of this ADAURA trial after maturity of 50% and the patients who have received the drug for at least 3 years. We will focus on the results DFS according to the stage, according to the CNS disease, and we will focus on the toxicity of the drug. Next slide, please. So these are the baseline characteristics, and we can see that both the arms were well balanced in terms of age, smoking history, race, performance status, and stage of disease. Majority of patients were of adenocarcinoma histology. EGFR exon 19 deletion was in around more than 50% cases, and it was 45% cases were of L858R mutation. More than 50% patients have received adjuvant chemotherapy in this setting. Next slide. So now we look at the results. These are the updated DFS in stage 2 and 3A stage. That was the primary endpoint. And here we can see that there was significant improvement in the DFS with osimertinib, with hazard ratio of 0.23, means there was 77% reduction in the risk of recurrence of disease with osimertinib, and the PFS was 65 versus 21 months. Next slide. These are the results in overall population, means here we have included stage 1B disease also, and here we can see that there was significant improvement in DFS, 65 versus 28 months with hazard ratio of 0.27. Next slide. This is the subgroup analysis. We can see that all the patients were benefited with the osimertinib. We should focus on the stage. We can see that patients who were having stage 3A disease, they were benefited more in comparison of stage 1B and 2. Patients who have exon 19 deletion, there was slightly more benefit in these patients. And patients who have received adjuvant therapy, the results were more favorable with osimertinib in these patients. Next slide. Next slide, please. So these are the results according to stage. Here we can see that patients, as that stage advances, the benefit was more with osimertinib. Here we can see with stage 3, maximum benefit was with stage 3A. The hazard ratio with for stage 1B was 0.41. It was 0.34 for stage 2, and for 3A it was 0.20. And here we can see the curves are also reflecting the same things. For stage 1B, the benefit was less, and it was maximum with stage 3A. Next. These were results according to AJCC 7, and the authors again restaged the disease according to AJCC 8th edition. And the results were consistent in all the stages with when the disease was staged at AJCC 8th. Next. So this is the pattern of recurrence of disease. Here we can see that maximum recurrence occurred in lung, lymph nodes, CNS, and bones. The most common first site of recurrence was it was around 12% in patients in placebo arm, and it was 26% in patients who received 26% in patient in placebo arm, and it was 12% in patients who received osimertinib. Here we can see that the CNS recurrence in lymph node, all were benefited with osimertinib, and rate of recurrence was very low in these patients. Next. So if we focus on CNS disease, the CNS DFS in patients with stage 2 and 3A, there was significant improvement in DFS, and it was not reached in both the arms, but there was significant improvement in hazard ratio of 0.24. Next. And the estimated probability of observing CNS recurrence in absence of non-CNS recurrence or death at 36 months was 2% in osimertinib arm, and it was 13% in placebo arm. Next. Next slide. Now we come to the toxicity. Here we can see that the toxicity was consistent with the previous analysis, and there was no toxicity was higher in osimertinib arm, but there was no adverse effect that leads to death in both the arms. Next. Diarrhea and skin related adverse effects were more with osimertinib, and interstitial lung disease was observed in 11 patients who received osimertinib, and QTc prolongation was reported in 30 patients in the osimertinib arm versus 8 patients in placebo arm. But the drug was well tolerated. Next slide. So with this analysis, after 3 years, when patient have completed 3 years of osimertinib, we can say that there was 77% reduction in the risk of recurrence or death with adjuvant osimertinib versus placebo in stage 2 and 3A population. That was the primary endpoint. Median DFS was 65 months versus 21 months. And there was also 73% reduction in risk of disease recurrence or death in all patients, including stage 1B. There was improvement in DFS was seen regardless of whether patient received prior adjuvant chemotherapy or not. And the benefit was consistent with the AJCC 7th and 8th staging, and the osimertinib demonstrated clinically meaningful improvement in CNS disease also. So we can say that after 3 years, the safety profile was consistent with established safety profile of osimertinib, and there was no safety concern reported in this study after 3 years. So we can conclude that these updated data reinforce adjuvant osimertinib as the standard of care for patients with EGFR mutated stage 1 and 3A NSCLC after complete tumor resection with or without adjuvant chemotherapy. Thank you. Thank you for patient listening.
Thank you, Dr. Ajay. So